Hello, I'm Mikhail Kosiborod, cardiologist and vice president for research at St. Luke's Mid-America Heart Institute and St. Luke Health System, and professor of medicine at the University of Missouri, Kansas City. We knew in the beginning of the pandemic that patients that have cardiometabolic risk factors like heart failure, chronic kidney disease, atherosclerotic vascular disease, hypertension, and type 2 diabetes are at high risk for developing more severe disease if they're infected with SARS-CoV-2 or develop COVID-19. They may not necessarily be at higher risk of being infected, but once infected, they're at much higher risk of having more severe disease, requirement for hospitalization, and if hospitalized, at higher risk of developing organ failure and death as complications. We also became aware very early in the course of pandemics that it's not just a respiratory illness, but it's also a systemic illness impacting not just respiratory system, but also cardiovascular, kidney, and other organ systems. And so it's really a multifaceted disease that requires organ protection to try to reduce the burden of complications of organ failure and death. And then, of course, we had data from large clinical trials of SGLT2 inhibitors in patients with those very same conditions, those cardiometabolic conditions like heart failure, CKD, type 2 diabetes, that showed that these medications can provide organ protection, certainly cardio and nephroprotection, under more stable circumstances in patients with those chronic diseases. But we didn't have the data about whether those medications could potentially provide similar organ protection in an acute setting like COVID-19, but there was certainly enough data there to potentially suggest that that may be the case. We just needed to be tested, of course. And we also had mechanistic data from both preclinical and human studies suggesting that some of the key pathophysiologic processes that are impaired in the setting of COVID-19 that drive complications, such as inflammation, oxidative stress, endothelial dysfunction, tissue hypoxia, may be favorably impacted by use of SGLT2 inhibitors. So I would say the hypothesis that we tested in DARE-19 as a result was pretty straightforward, which is, we hypothesized that dapagliflozin, which is an SGLT2 inhibitor, can provide organ protection, prevent organ failure and death, and potentially improve time to clinical recovery in patients that have those cardiometabolic risk factors and are hospitalized with acute COVID-19 illness. DARE-19 included patients that were hospitalized with COVID-19 for no more than 4 days and had requirements for oxygen support, as well as had cardiometabolic risk factors. So they had to have at least one risk factor of either hypertension, type 2 diabetes, heart failure, regardless of ejection fraction, chronic kidney disease, or atherosclerotic vascular disease. And the key exclusion criteria were critical illness on presentation, GFR less than 25, and prior history of type 1 diabetes or diabetic ketoacidosis. Patients were recruited across 95 sites in 7 countries, so this was an international trial. And we recruited those patients between April 22nd, 2020 and January 1st, 2021. The trial design, again, was relatively straightforward. Essentially, if patients fit all the inclusion, none of the exclusion criteria, and agreed to participate, they were randomized to either dapagliflozin 10 milligrams once daily or placebo and treated for 30 days. During those 30 days, patients had assessments while they were in the hospital, actually daily assessment of their clinical status and surveillance for any kind of complications, organ failure events, as well as safety events. And we had several key safety events that we were following, including acute kidney injury and diabetic ketoacidosis. And once they were discharged, they were followed by phone calls. And the treatment was continued for 30 days, regardless of whether patients remained in the hospital that long or whether they were discharged home. Following the cessation of treatment at 30 days, we had an additional 60-day observational follow-up period. So the total duration of follow-up was 90 days, but the treatment was stopped at 30 days. And the primary efficacy and safety data, as pre-specified in the statistical analysis plan, was for that 30-day treatment period, which is what we just presented at American College of Cardiology Congress. So just to remind everybody, we had two primary endpoints. The first one was a composite of time to a first event of organ failure or death. So that included respiratory, cardiovascular, or kidney dysfunction, organ dysfunction, or death from any cause. And the second primary endpoint was hierarchical composite of recovery that really spans the entire spectrum of clinical recovery, from bad outcomes like death or organ failure to good outcomes such as faster time to hospital discharge. And then we had a number of secondary endpoints, including composite kidney outcome and all-cause mortality. And we also had safety endpoints, which included serious adverse events and adverse events of special interest, which were acute kidney injury and diabetic ketoacidosis. So in terms of discussing the results, I mean, we should probably dissect this into, the efficacy and safety data. So we'll start with efficacy. So our first primary endpoint was a composite of organ failure or death. I will preface the results by reminding everyone that this was a very unusual time in terms of when to do a clinical trial, especially in COVID-19, because we were studying disease for which the standard of care was rapidly evolving as we were doing the trial. So when we started the trial, the rate of complications and death was extremely high. So this is March and April of 2020. So just to give an example, in New York City, for instance, at that point in time, 25% of patients that were hospitalized were dying during their hospitalization. So that was March, April of 2020. By August of 2020, that rate of death for hospitalized patients in New York City was about 5%. So it went down fivefold. And something very similar was happening in the UK and elsewhere at the same exact time, because the standard of care was improving and rapidly evolving. And so when we designed the trial, we expected a certain event rate of organ failure and death. And the event rate that we actually ended up observing as we were in the middle of our trial, when all of this rapid improvement in outcomes has been happening, or was happening, what we observed in terms of event rate was very different, was much, much less. So the number of events of organ failure and death that we ultimately ended up accruing was considerably lower than what initially was anticipated. So with that preface, there were a total of 156 events in those 1,250 patients that got randomized. And we observed 70 of those events in the dapagliflozin group and 86 occurred in a placebo group. So numerically fewer events in the DAPA group as compared with placebo. The hazard ratio was 0.80, but the 95% confidence interval spanned 1, and the p-value was 0.167. Which was obviously not statistically significant. So directionally, the results seemed favorable to dapagliflozin, but did not reach statistical significance. Same was the case for components of that composite outcome. So we observed that the hazard ratio for each component of that composite outcome, including respiratory, cardiovascular, kidney failure, and death from any cause, directionally favored dapagliflozin as compared with placebo, but were not statistically significant. Now shifting to the second primary endpoint of recovery, which again included not just bad outcomes like organ failure and death, but also good outcomes, such as faster time to hospital discharge. A vast majority of patients in the trial, over 85%, ended up being discharged from a hospital without having an event of organ failure or death. And dapagliflozin did not have a significant impact on time to discharge, which drove most of that outcome. So the way we express that hierarchical composite in terms of summarizing the results is the win ratio with values greater than 1 favoring dapagliflozin as compared with placebo. The win ratio was 1.09. So again, directionally favoring dapagliflozin, but the 95% confidence interval, once again, crossed 1 and the p-value was not statistically significant. And again, that was predominantly because most of that outcome was driven by time to discharge and there was no effect of dapagliflozin on time to discharge. As far as secondary outcomes, composite of kidney events and all-cause mortality, same kind of story where there were fewer of those events in the dapagliflozin group as compared with placebo, both for the kidney composite as well as all-cause mortality. So the point estimates were directionally favorable to dapagliflozin, but first of all, those secondary endpoints should be considered as exploratory. Because we didn't meet our primary endpoints at the significance level we pre-specified. But again, the 95% confidence intervals for those secondary endpoints composite of kidney events and all-cause mortality crossed unity and were not statistically significant. And then finally, shifting to safety, that was a critical component of the DARE-19 trial because, as some of you may know, there were concerns that were expressed about using SGLT2 inhibitors in the setting of COVID-19 early on in the pandemic because of potential for things like acute kidney injury and diabetic ketoacidosis. So some professional groups and expert groups issued recommendations early in the pandemic that if the patients are already on SGLT2 inhibitors for other indications like type 2 diabetes or heart failure, if they get admitted with COVID-19, those medications need to be stopped. And so we monitored, as a result of that potential concern, we monitored safety very, very closely in the DARE-19 trial. So especially in patients with diabetes, they had daily assessments of acid-base status, and there was a active surveillance for diabetic ketoacidosis with required investigations if any acid-base imbalance was noted. So, of course, we also had very close surveillance for acute kidney injury as well. There was a independent data and safety monitoring committees that oversaw the safety findings very, very carefully. At the end of the day, what we observed was actually that there were numerically fewer serious adverse events in the dapagliflozin group as compared to placebo. That included numerically fewer serious adverse events with a fatal outcome in the DAPA group as compared with placebo, and numerically fewer serious adverse events that resulted in discontinuation of study medication, and numerically fewer serious adverse events of acute kidney injury in the dapagliflozin group as compared with placebo. There were only 2 cases of diabetic ketoacidosis. Both were non-severe. Both occurred in dapagliflozin group and both in patients with type 2 diabetes. So overall, I think the safety data was very favorable. It clearly indicates that dapagliflozin is well tolerated in this group of patients that are acutely ill with COVID-19 and are hospitalized, and no new safety concerns were identified. I think there are a number of implications here. So let me first kind of summarize the key findings. So as far as the effect of dapagliflozin on primary outcomes of prevention of organ failure or death or improving clinical recovery, we did not reach statistical significance for those endpoints. However, we observed numerically fewer events of organ failure or death in patients treated with dapagliflozin as compared with placebo. And that was consistent across each component of that composite outcome of organ failure or death, cardiovascular, respiratory, and kidney decompensation, as well as death from any cause. And overall, dapagliflozin was well tolerated with no new safety findings identified. The implications, I think, are twofold. One is potential implications for clinical practice, and I think that's where the safety data is so important. As I mentioned before, there were some potential concerns about using SGLT2 inhibitors in the setting. Because we thought that dapagliflozin was well tolerated with no new safety concerns or signals identified, our results do not support discontinuation of SGLT2 inhibitors in the setting of patients being hospitalized with COVID-19 if they have other indications to be on them, such as type 2 diabetes, heart failure, or potentially chronic kidney disease in some countries. So patients, of course, should be monitored during hospitalization, as we did in the trial, but provided that they're monitored, there is no clear reason why those medications need to be discontinued. So I think that's pretty clear implications when it comes to clinical practice. There are also implications for future research. Even though the trial did not reach statistical significance for the endpoint of organ failure or death, again, we had substantially fewer events for that endpoint that would have been required to demonstrate statistical significance given the treatment effects that we observed. And the hypothesis that we had in the beginning of the trial, which is that dapagliflozin may provide organ protection in the setting of acute illness like COVID-19, I think from a standpoint of this trial being proof of concept and hypothesis generating, I think it clearly supports this hypothesis that there may be an effect in terms of organ protection. It doesn't prove that hypothesis. We didn't prove it definitively, but it certainly generates a hypothesis that dapagliflozin may provide organ protection in a setting of acute illness such as COVID-19. But in order for that hypothesis to be proven, it would need to be further investigated in future and likely larger clinical trials. And because dapagliflozin is not an antiviral drug, I think another scientific important implication for future investigation is that if dapagliflozin does in fact provide organ protection, the setting again something we'll need to prove in future trials, it may be actually the case beyond COVID-19. It may extend to other types of acute illness, such as sepsis and maybe others. Again, something that we'll need to study in future trials.